This is Jerry Hesch. This is an emerging model of pubic symphysis dysfunction and symphyseal diastasis, evaluation and treatment, part 2. So if we talk about the ligaments in the SI joint and symphysis pubis, they have certain properties. These are the constituent substance that makes up a ligament: collagen, elastin, ground substance. And don't need a lot of detail in this right now. With respect to the SI, the ratios are unknown, and same for the symphysis pubis. We don't know how much elastin there is versus how much collagen, as opposed to ground substance. And the elastin is the stretchy stuff, just like elasticity, just like the word elastic. But there's a distinct exception. An acquaintance of mine, Roy Bechtel, I believe he's at University of Maryland, and I believe he's retiring January of 2012, did a really remarkable study of the axial part of the interosseous ligament. And what he found was that it has less collagen and less elastin. So this is a very different beast, this axial ligament. And this will become important to us later when I give a theory about how this ligament is part of the process of symphyseal diastasis. And it's a rather stout critter in that it occupies 14% of the posterior ligament space of the SI joint, which is very vast. I mean, there's an awful lot of real estate there for ligaments. If you were to look at the tuberosities on the sacrum behind the joint margin, behind the hyaline cartilage, and the same thing on the ilium. So it's also called Illy's ligament. It's in the upper part of the joint. It's behind the joint. Ligament, of course, connects sacrum to ilium. And why would we have this odd departure from a typical ligament? Why does it have less collagen and elastin? One theory is that it functions as an axis, and that's fairly well accepted. But here's another function that I'm going to propose, that perhaps it acts as a strut during birth. Now this is the only primarily round ligament of the posterior SI joint. The others are more planar or have altered shape along their origin and insertion, such as the sacrotuberous and sacrospinous. If you do a detailed look, you'll see that they kind of fan out, whereas the axial from beginning to end remains fairly circular. So here's the location. You're looking at the inside of an ilium. This is the inside of the right ilium, and my pointer's not doing me much good. I have a laser pointer, but it doesn't show well. This is the ASIS. This is the pubic bone. This is the ischium, ischial tuberosity, and the PSIS, posterior superior iliac spine, is right here. Well, here is the articulating part of the ilium, which is made up of fibrocartilage that makes up the SI joint when it connects to the sacrum. And all of this is the iliac tuberosity, just full of ligaments. And then back here there's some muscle, but honestly, tremendous amount of ligamentous territory there, primarily the interosseous ligament. And this round critter there is the axial ligament, Illy's ligament. So we're going to move on and talk about pubic joint dysfunction. We're going to talk about pain, which can occur with increased motion and increased gaps, such as occurs during pregnancy or with trauma. But typically, the demarcation is 10 millimeters. If you have 10 millimeters or less of spreading of the symphysis pubis, it's not considered a rupture. It's not considered what they call a diastasis, but rather is described as pubic joint dysfunction. It's an increase in mobility, but in general, it usually is not an instability. I'm sure there's individual differences based on different body types, in which in a very small person that might be a significant gap. But for the majority, they manage fairly well with 10 millimeters width at the mid-pubic joint during pregnancy. So diastasis is a whole other entity in which the pain is much more profound and than it is with symphyseal dysfunction. It's a literal tear. It's a literal separation of the pubic bones away from each other. in which the midline width of the symphysis pubis is greater, is 10 millimeters or greater. Now there's some wonderful review articles that demonstrate that there really is a current knowledge gap. And Becker did a beautiful review article in 2010 that's referenced later on. Now, let's talk about pubic joint dysfunction and how it progresses to symphyseal diastasis. It's imprecise. This is according to Becker. It's variable. It's unknown and unpredictable if there is no prior history. So you don't know that a certain person has a vulnerability to that if it's their first pregnancy or if they have not experienced it before. And there certainly are a handful of articles on this problem, but there is not, you couldn't say that there's hundreds of articles and that the knowledge is deep, surprisingly. We will talk about why that is so later on. So the statistics are also variable. It depends on how you look at the data as to how you come up with numbers. So different studies may come up with somewhat different numbers. Sometimes the numbers are similar. It depends on what your measuring tool. But nonetheless, this is very important information to say, look, there's a problem. It's in the minority of these folks, but when they do have it, it's a significant problem. That's how I read this. So what I'm reading is that 3% of the obstetric population will have symphysis pubis dysfunction, in which it's spreading up to 10 millimeters and it is causing local pain. However, 25% of that 3% are still symptomatic 6 months after birth. So those folks 6 months after, they're still hurting in that area. It's still impacting their life. And the author of that was Owen, 2002. Ledbetter, in 2006, did a nice article, and found that in the first trimester, his population, about 12% of them had symphysis pubis dysfunction, which increased to about 57% in the third trimester. Is it a good thing or a bad thing? Well, you do have to, let that, the child has to be born, right? The infant. It has to move through the pelvis. So spreading of the symphysis pubis is a physiological it's a normative function, and I think these folks probably have very good deliveries because there's a little more slop in the system that allows an easier birthing. That's my theory. Okay, so here's the funny thing, and this is the absolute truth. With respect to obstetric symphysis pubis dysfunction and even diastasis, the cure is very simple. The cure is delivery. Not 100%, that's the point. That's why we're doing the slide program. So a large number of these folks, once they deliver, the wisdom of the body, Mother Nature, takes over and healing occurs, and they go on to live healthy, productive lives. They go on to have more children. They're not stuck in that chronic pain rut. There is unfortunately a small percentage, and that's why we're doing this presentation. We're concerned about those who do not heal, and that's why we need to evaluate the biomechanics, because if we have a deeper understanding, if we can learn more about it, we can learn more about optimal treatment. So, there is some articles. There's a study that shows that in Zimbabwe, it's a very important life-saving maneuver in which they actually cut the symphysis pubis during childbirth, called a symphysotomy. Otomy means cutting. And, they imply that there's no long-acting, no long-standing dysfunction associated with this, but they do not track the statistics. And we do know that different populations have different types of bony development. So you ask the question, can they recover more so than, say, a Northern European population? And that's simply a question that we don't know. There was an article in Nigeria in which they were reporting on 7, failures to heal with the symphysotomy, And certainly several countries have websites for symphysis, pubis dysfunction, and diastasis. Great Britain, Ireland comes to mind, and there are several others. So, again, delivery is the cure for most, but as noted in the earlier statistics, some continue to suffer, some severely with major quality of life impact. Treatment evolution is needed. All right. There aren't a lot of hard science studies in the obstetric population. There are studies in the orthopedic literature, and there is a classification of pelvic instability from external trauma, such as a car wreck, a fall, etc. And Tile in 1996 came up with a classification for anterior to posterior compression injuries of the pelvis. So if we look at this data and we understand the basic classifications, I believe there's some nuggets, some real gems that we can extract from and see if they apply to the obstetric population. So an APC1 is a symphyseal diastasis only, and they heal with conservative care. So this is a person who had say a motor vehicle accident, and the steering wheel, created an anterior to posterior compression injury in which the symphysis ruptured, but using a binder, an SI belt, trochanter belt, etc., conservative care for a few weeks, bingo, they recovered. An APC type 2 involves a symphyseal diastasis, the same as the type 1, but the anterior SI ligaments rupture, and these people are treated with a plate screws, surgical fixation of the symphysis pubis. Now, an APC 3 includes the above two ruptures of the pubic joint, the anterior ligament, but also the lower ligaments of the SI rupture, which are the sacrotuberous and the sacrospinous. So those folks have more extensive surgery. They have a plating done at the pubic joint in the front, and both SI joints are fused in the back. That's bilaterally done. The sad news is a fair number of that population does have a chronicity in their symptoms, and some of these people, these are very life-threatening injuries. Now, there was a really nice study done by Gardner et al., published in 2010. And it was a simulated recoil study. And what they did was they found that with a diastasis, they were able to enhance it as wide as 5 centimeters. These were cadaver models. And when they took the stress away, within 30 seconds, it closed from 5 centimeters, that's 2 inches, to 2.5 centimeters. So it reduced in half very quickly within 30 seconds per x-ray. So what they're implying there, what is the clinical application? What they're saying is that x-rays are inaccurate in that they do not show the severity of the injury. If someone was going to get in a car wreck and you could put sensors or an x-ray machine inside the car, record the injury, record the split, and say, well, Joe had 5 centimeters of gapping, and now that he's at the ER, it's a couple minutes later or 10 minutes, an hour later, and we do an x-ray, we're now finding 2.5, but Joe, we saw you in the car wreck and we measured it and it was severe. So therefore we're going to give you more extensive treatment will be necessary than for that one. That'll become more meaningful in the next couple of slides. Here's a picture of a type 1 AP compression injury so that only the symphysis ruptures. In a type 2, you get symphyseal rupture here, and you get rupturing of the ligaments that are in the front of the SI joint. Okay? In an APC 3 injury, you have the separation here, and it's of increasing amount. This would be a mild separation. This one is getting more severe at 50 millimeters, and this one becomes very severe because there's this torquing that happens, because not only is the anterior ligaments, but also these lower ligaments, not visualized here, but these lower ligaments, sacrotuberous and sacrospinous, rupture. So it's a progressive injury, of course, Now, recall we said that the APC type 1 is actually, it's a form of uncomplicated sacroiliac diastasis in which it should heal readily, and the x-rays are similar to CAT scan. They're within 1.4 to 1.6 centimeters in a population, so they're off by just, 2 millimeters? So that's good news. And with applying stress, they found in this population that had this degree of separation, when they applied physical stress to try to increase the widening, it went up to 2.5. What does that mean? It means these people initially were treated conservatively. They were treated as though they were a type 1 injury, but when physical stresses were applied to that symphysis pubis, it was determined that they increased to 2.5 centimeters. It was determined that they were actually a type 2. And so now they need surgery. They need an anterior plating. So the concept, the take-home concept, is that you should always stress those to see if there's further widening. There's a gray area with respect to diastasis between 10 and 18 millimeters. Typically, conservative care is successful, but it is a gray area. Typically, 18 millimeter, 1.8 centimeters rather, 1.8 centimeters will be a stable widening, and they should be successfully treated with conservative care. You go over here to 4.5 centimeters, and it's determined that it's definitely unstable, definitely is a surgical case. But here is this big, wide, gray area in which sometimes folks heal and manage okay based on their lifestyle, body type, etc. But there are certainly some probably way down here and some way over here who end up requiring surgical stabilization. So understanding the gray area is very important, as much as it is in understanding both extremes. Again, here's a physical stress being applied in which the pelvis would gap laterally, and then there's also a rotational force applied, and you can measure the gain in the width between the two pubic bones. And this picture shows a superior-inferior overlap and crossing over of the pubic bones. Physically stressing them is very important, rather than just taking an x-ray and say, oh, it's stable, it's only 18 millimeters wide. It's important to go in there and physically stress it and find out if that's really true. Now we're getting back to that recoil study we mentioned. This is the initial diastasis of 50 millimeters, and this is the relaxation that happened a short time thereafter when the forces were removed. Here's a very severe injury, and when the forces were removed, you can see in both of them almost, approximately a 50% reduction in that width. So that's a very, very important understanding. And this one, even though it recoiled by 50%, it was still an unstable amount of gap at 50 millimeters, whereas this one that had a fair amount of disruption, reduced to being less than 25, and this one was partially stable, perhaps in that gray area. Here's a very good picture if you can follow this. I know it's not a huge image, it's a little tricky, and why my pointer works on my hand and not on the image, I don't know, but I'll use my pen. See the blue arrow? Tremendous gapping of the sacroiliac joint. The distance should be more like this. On a real image, it should be about 2 millimeters at most average. So here we see, before they apply a sling, around the ischial tuberosity, a sling around the pelvis to close that up, there's tremendous gapping of that SI joint. And look what happens after they apply the sling. Fabulous. So the sling is simple procedure, can do much. And once you close up that joint, then healing can start to happen. The body can start to lay down scar and recover. Whereas out here, oh my gosh, it's just much too wide. I can't even fathom the kind of dysfunction and pain that is suffered by those folks. Now, again, this is the SI joint. So let's look down here. Look at the symphysis pubis. This is the top of the hip joint. This is the top of the femoral head. That's a slice way down in the lower part of the pelvis. And this is just a tremendous spread at the symphysis pubis. And again, follow the yellow arrow. They apply a sling. And look at how that closed up and allowed Mother Nature to induce healing. So a very simple structure, application of a binder, a trochanter belt, SI support worn very low, can be very, very therapeutic. I don't recall the timeline between these x-rays, but there you have it. Certainly, the wisdom here is early intervention yields the best outcomes. Some cases are underdiagnosed. Some people don't have the knowledge base about these kinds of injuries, because if you'll recall back, they're in a very small percentage of the population go on to have long-term diastasis. So recall that in the previous x-ray, that person looked like an APC1 at the first x-ray. I'm sorry. Ignore that statement, please, but recall earlier that I was talking about that at times an APC classification 1 injury is actually an APC 2 or greater, which then moves them into a surgical category. The point being, what you see on the first x-ray, there actually may be a greater trauma, and stressing that pelvis to see if the joint widens further is very important in terms of patient management. Surgical planning. Are they surgical or not? So there is some good news. Let's talk about a case study. This was a wonderful study. This is a case of severe obstetric symphyseal diastasis, co-walk. Brilliant, very encouraging paper. I mean, if you look at this, it just looks frightening. This is the right pubic bone. This is the left pubic bone. I mean, the distance is just horrendous. It's 4.5 centimeters. Terrible. What's the good news about this? I'll lead to it in the next slide, but look at this, the SI joints. If you just looked at the SI joints, you would not understand that they were unstable. They are. If you had a transverse image of the SI joints, you would have more information, I believe, in this case. But you cannot look at the front of the joint and say, oh, the SI is stable, because if this is unstable, absolutely, both SI joints are unstable. It's one ring, it's one system. Now, this x-ray is really interesting, and that's the same person. This is a transverse image. This would be approximately the ASIS. I'm sorry, it's not a transverse image, it's more of a vertical image. It's a coronal image, my mistake. But it does show, and I say that because you can see the first foramina here. It does show tremendous gapping here. This is abnormally wide if you would look at normals. It also looks like the sacrum has glided forward. It may be at an angle. I'd have to see the entire CAT scan and see the scout image to find out how they measured it, which angle, whether it's... Regardless, here's the point I want to make. It looks like the sacrum is anterior to the ilia at the joint, or it looks like the ilia came back, and actually the SI joint is now open on both sides, but actually this space back here seems to create a new kind of a joint. This is where the interosseous ligaments are in the SI joint, and typically there's more space away from that. If you would see this part of the ilium come in to the sacrum, obviously this part would gap out, and that is typical anatomy. So what I'm leading to is I think this actually teaches us a lot about symphyseal diastasis. I think what happens is that the pubic joints, which aren't seen in this image, don't just come across this way. There's actually a cam action in which the iliac bones come backwards. They open laterally, the pube bones go anterior and lateral, and then these glide back. Now, this is the same client. I would have thought, I think everyone would have said, that's a surgical candidate. This poor person really needs surgery. Look at how wide that gap is. This is that person 6.5 months later. Look at the callus formation. You can see the bone bridging right on that upper part of that pube. And all of this is, calcification. The body is saying, we better create some bridging here. We better stabilize this structure. So at this point, she now is only 1.5 centimeter. And was treated conservatively. So there are times when someone doesn't have access. There's parts of the world where they don't have access to surgery. So we need to know what are the alternative methods of helping these folks. Still, that's a little more widening than I would like to see. But we don't know the details about this case. We don't know how compliant the client was in wearing the binder, etc., etc., etc. And of course, if this bone should fuse, and should she ever have another child, well, surely she would require a C-section. Right? I mean, because this is just not going to open. It's not going to allow childbirth, to the best of my understanding. Okay. Here is a very insightful statement, again made by Kowalk, and this was in 1996 Journal of Bone and Joint Surgery. Obstetric symphyseal diastasis is nearly the opposite mechanism of APC injury, so treatment should differ. And I underscore this. Everything I'm talking about is based on this single statement, and I do think the treatment does need to be different, which I will elaborate upon. Now, if we look at the traditional model of birth mechanics of the pelvic joints, the ischia spread laterally, which increases the lateral dimension. I'll show you a picture shortly. I'm quoting Kapanji, who references Faber-Boe. I believe that that's a 1910 reference, but it's not clearly indicated. There's very little, in fact, in the literature to describe definitive biomechanics of birth, which truly surprised me. The sacrum nutates, in which the base moves anterior, inferior, and the bottom of the sacrum, the apex, moves posterior and superior. We'll show you a picture here. So what we're saying is the ischia, the bottom, spreads laterally, which would cause a little bit of a compression at the superior pubic bone. The ilia infold because the bottom, the ischia, outfold, okay? And then the sacrum rotates forward. That's called nutation. So the top of the sacrum moves forward and the bottom moves out. And this is when the baby is moved out of the upper canal down into the lower canal. And this would maximize, the opening of the pelvic outlet. So these biomechanics certainly make good theoretical sense. I sincerely don't think they've ever been literally studied with movement analysis such as fluoroscopy, etc. Wouldn't make sense. I mean, it would not be allowed. So I think there is a degree of guesswork here. And so to contrast, a motor vehicle accident would cause an anterior compression, causing fracture. The pelvis striking the steering wheel, for example. Whereas obstetric diastasis, the forces from the inside pushing out, actually pushing in all directions, causing the rupture. Now, if I understand correctly, the pubic joint is perceived to widen, and if diastasis occurs, pubes are described as moving laterally, although I'm unsure if it is believed that the pubes also simultaneously move anteriorly. And I am proposing that they probably do move anteriorly because that would allow further maximization of the outlet dimension. Okay? And this is sacral nutation described a little bit more. This is Kapanji's book, and in nutation, any of the blue ones are nutation, in which the top of the sacrum goes in and the bottom goes out, and this would increase the anterior-posterior dimension of the pelvic outlet. So here's another view. Here's the sacrum. This is an outside view. There's some ligaments there. This is the ilium, the outside of the right hip. Here's the right pubic bone. And basically with sacral nutation, the bottom of the sacrum moves backwards and up. I should have altered that arrow a little bit because it goes, backward and up a little bit. My mistake, but that would increase the anterior-posterior dimension. Now, bench testing, I took a ligamented model and I took it in the garage and set it up on a vise, and these were flexible anatomical models. Oh, first I used one without ligaments and then I did one with ligaments. Played with it and said, what happens if we do this and then that? And the question I kept asking is, which one maximizes the dimension? Absolutely, a limited number of permutations are available. It can't do anything. It has specific constraints. And I agree with this model. However, this model describes kind of normal childbirth. It describes perhaps a normal symphysis pubis dysfunction, but the diastasis is a different beast. It's a different entity. So if diastasis occurs, there probably are additional pathomechanics that occur simultaneously which have not been described in the literature. So my theory is going to be predicated on these basic premises. One, in that the body minimizes injury. We have to deliver the baby, but let's design this structure so that it can deliver the baby even if it gets injured, such that it can minimize that injury and recover. Second one, which I believe everyone accepts, is that form, the body structure, the way it's developed, the morphology, and function, the way it moves, the way it functions, are inextricably linked. They cannot be separated. Okay? Anatomical details and research can support or negate novel theory, so the things I propose here can be validated or invalidated, or may be given the stamp of sometimes. So, in describing obstetric diastasis, if the pubes only moved laterally, then the sacroiliac joint would compress to its maximum of non-yielding 2 millimeter. That's the maximal amount that the SI joints could compress, at which point there would be cartilage against cartilage and no further movement. Now, question, could those kinds of forces lead to fracture? Maybe. We don't hear about obstetric fracture. This is not very efficient. Only 2 millimeters, of course it's on both sides, so you could say it gains 4 millimeters in a normative joint space, but I think there's another mechanism that gives them a little bit more space. So, symphyseal diastasis facilitates the greatest gain in dimensions in all directions, first in the pelvic outlet as the baby's descending, and then ultimately in the pelvic outlet. So all dimensions increase, especially to let that baby traverse it. So, progression. After normal mechanics prove inadequate, baby's growing, getting bigger and bigger, baby's got to come out, there's an otherwise abnormal cam motion that occurs during the enhancement of the existing mild pregnancy dysfunction or mild diastasis, which is now becoming pathological. And then I propose that the pubes don't just move lateral, but they move lateral and anterior. Anterior is the key concept that I bring to the table, allowing a greater excursion to maximize the outlet dimension. How? Why? Well, because the ilium glides abnormally as part of a cam-like motion, and that occurs on a vertical axis. It occurs along the parasagittal plane of the SI joint, which you could think of as a transverse slice of the body, which you could visualize in a transverse plane of the body, allowing the above movement. I know the biomechanical folks would get in trouble with those two sentences being connected, but I'm going to ignore that for now. The ilium then compressed medially and somewhat posteriorly against an unyielding axial ligament. Remember the axial ligament? Which acts as a bushing or a stop. I feel very strongly that one of the major functions of the axial ligament has to do with birth mechanics, because there has to be a spreading of those pubic bones, but then it needs to be stable. It needs to stay. Why? Because baby coming out through that canal takes time. So it needs to maximize the space, but it needs to stay there for a period of time. So I believe the axial ligament acts as a bushing or a stop. Remember, it has less collagen and less elastin. This then maintains the maximum outlet dimension until delivery is complete. Then the joints recoil. So what I'm saying is that when the pubic bones don't just come apart, that they go anteriorly in that cam type motion, that allows these mechanics, maximizes increased space. Again, you saw this earlier when I commented on it, and I showed that the SI joints were very much widened. Anyone would tell you that is an unstable SI joint, but they seem to create new joints in the back, in this area, where the joints come and become stable there for a period of time. I submit that the axial ligaments prevent those from coming any further, but also help maintain the opening in the outlet. So in my model for severe symphyseal diastasis is that the ilia on each side glide along the plane of the SI joint. It's a component of that cam motion, and this is supported by Kowalk's image. That's a CAT scan image, and this supports that. I wish that I had normal anatomy right here to contrast with you. I apologize, I don't. But if you look at normal anatomy, you'll find very few. You'll find the sacrum is not imaged anterior to the ilia. The joint is not this wide, and this in fact is not articulated like this. I think you can easily image that if we close this space, if we brought that ilium in, the space here would widen, and that is normative anatomy. So I think that this image was very, very helpful in our new proposed theory. Note the anterior gapping and the posterior approximation of the sacroiliac retroarticular complex. The SIJ now articulates behind the actual joint where the axial ligament resides. So, with obstetric diastasis, most patients heal, some up to 6 months postpartum, and resume normal asymptomatic function. Why? How is it possible? Let us explore the topic a little bit deeper. If we understand why they heal, what the mechanism is, perhaps we can help those who don't. And that will be part 3. We're going to come to that shortly. Thank you very much.